Between 2014 and now, he was an assistant and associate professor of pediatrics and immunology at the University of Pittsburgh, and recently joined our faculty here at the University of Minnesota. But before asking him to come up, I wanted to give you a little bit of background. As most of you know, in the setting of allogeneic hematopoietic stem cell transplant, what we're doing is we're replacing the diseased marrow, oftentimes with a hematopoietic malignancy. So we want to eradicate the tumor and also eradicate the immune system so that we can make a situation such that the new cells, the new hematopoietic stem cells from a different person won't be rejected. As you can see in this cartoon here, what we're trying to do is take patients and beat down the tumor by the chemotherapy with or without a radiation, and then affect the final cure by this something called the graft versus leukemia effect, which I'll describe to you in a little bit more detail. Maybe. Okay, next slide. So what you see here is what we're doing is doing this transplant where it's a mixture of hematopoietic stem cells, as you can see in here, as well as mature lymphocytes. The hematopoietic stem cells will home to the thymus to create a new immune system ultimately. But before that occurs, there's a peripheral expansion of those lymphocytes to be infused in the allograft. And these cells unfortunately cause graft-versus-host disease, which is a life-threatening complication that today we have significantly better ways of preventing graft-versus-host disease. But by so doing that, typically we either increase the risk of leukemia or relapse, or at best we keep it the same as what it was. But our ultimate goal here is to be able to prevent the graft-versus-host disease, which manifests as a rash, severe diarrhea, liver failure, and other organs if it's severe enough. But they're the three classical organs associated with graft-versus-host disease. But the patient doesn't die of the damage to that particular organ in most cases. But what happens dies from a profound immune deficiency state as a result of the therapy itself, as well as the GVHD that occurs. So what we want to do is we want to figure out better ways that not only reduce the risk of graft-versus-host disease, but also will prevent the risk of relapse. So some of you may have seen this before. Shernan Holton back several years ago did an analysis of our patients here, but receiving allogeneic transplant for hematologic malignancy. And what we typically have done in the past is our endpoints were either overall survival or relapse-free survival, as you can see here. But graft-versus-host disease can be a debilitating disease, and although it may not always kill you, what it can do, though, is it can create a lot of problems over time. And so what we then developed was a new metric, which was graft-versus-host disease-free, relapse-free survival. And you can see here the overall GVHD-free, relapse-free survival is only 31%. And our goal is to be able to improve that by reducing the risk of relapse and reducing the risk of graft-versus-host disease. This now moves us into the presentation, which is by Dr. Byersdorfer, as I said, who's going to speak on the metabolic modulation to prevent GVHD and to promote anti-cancer immune responses. Craig.
Thank you, John, for the introduction. And we'll let the expert take care of the slides here. Great. So as John alluded to, I'm going to tell you today about metabolic modulation to prevent GVHD and promote anti-cancer immune responses. Just to start, I do have one disclosure to make, and that is we do have 2 patents that were filed on the technology described in the second half of this talk, and I'll try to point out when that comes up in the talk. So as John eloquently described, bone marrow transplantation in humans is often used for people with sort of hematologic disorders that can be deficits in the immune system. It can also be malignancy, shown here for leukemia. And what happens is these patients or recipients are often sometimes called the host, undergo a conditioning regimen with chemotherapy and radiation. We then obtain bone marrow stem cells from a healthy human donor that along with the stem cells also contain immune cells. In this case, they're T lymphocytes. And that whole sort of mix is then infused into the conditioned recipient or host. Now, the T cells that come along with the graft have positive attributes. They can help fight infection. They can also mediate graft versus leukemia responses. However, the negative or downside to this is they can also, the T cells from the graft can attack and destroy tissues in the host, including in the skin, liver, and the gastrointestinal tract. And this is what we call graft versus host disease. And so obviously the true holy grail of this would just sort of be to promote the positive benefits while minimizing the negative aspects of this. You can actually model this in animal models, and this is going to be sort of the classic slide that I'll show you multiple times throughout my talk. And that is where we essentially take cells, T cells that are from one parent strain, and put them into an F1 generation that's a cross between two parents. These mice have been lethally irradiated, and it's really the T cells from the parent one that are recognizing things that are foreign as donated by the parent two strain that causes this GVHD reaction. Now, by marking the cells congenitally prior to the transplant, you can actually evaluate them and pull them out on day 7 to ask mechanistic questions about what's going on in this GVHD process. So one of the first things that they did a number of years ago, this was when I was a postdoctoral fellow in Jamie Farrar's lab at Michigan, is they simply went in and looked at how much oxygen consumption is going on, shown on the y-axis here, of the T cells, either pre-transplant, so that's the naive cells, or post-transplant. And so what you can see is the post-transplant T cells have a greatly increased oxygen consumption, which is really suggestive of an increased reliance on oxidative metabolism. Now, this is a little bit paradigm shifting at the time, because up to that point in time, everybody thought that a quiescent T cell would do oxidative metabolism, but then an activated T cell would do glycolysis. But it's really demonstrating here that activated T cells can do some oxidative metabolism. My lab has gone on to do similar studies, again, looking at oxygen consumption here in the y-axis. Now we're adding this additional component of looking at glycolysis. And really what you see is that compared to the naive T cells in the bottom left here, is that the alloreactive T cells have an upregulation of both oxidative metabolism and glycolytic metabolism. So then what we really wanted to know is what is sort of causing this? What are the mechanisms to allow the cells to have this upregulated or change in metabolism as a way to potentially drive a therapeutic wedge to treat the GVHD. We became interested in this protein called AMP activated protein kinase. It's a heterotrimer consisting of a regulatory gamma subunit, a structural beta subunit, and an alpha subunit that has a kinase domain. When the cellular energy levels fall, this protein is activated and the alpha subunit kinase activity picks up, and it sort of phosphorylates a bunch of downstream targets. We were interested in this because it interacts with multiple other metabolic pathways, including things like mTOR, which we know plays a role in GVHD T cells. That's the sort of the target of rapamycin. It's also known that AMPK is a known driver of oxidative metabolism in a number of other tissues and cells, is demonstrated here. And so we became interested to see if it was functional on our GVHD causing T cells. So the first thing we did is we just went back to our model, which I've already described. We recovered the alloreactive T cells or GVHD causing T cells on day 7. And we simply did Western blot analysis. The first thing I should tell you is that AMPK, when it becomes activated itself, becomes phosphorylated in a very particular way on 3-adenine 172. And you can actually follow that with a specific antibody that's been developed. So if we look on our day 7 T cells now from the GVHD animals, what you see is you see an upregulation or an increase in the phosphorylation of AMPK to show that it's active. That does not occur in the naive T cells prior to transplant. We can also run a syngeneic model where we take cells from the same background and put them into the same background that have been of irradiated mice, where there's no GVHD, and those mice also don't upregulate the pathway. You can also look for the upstream protein that sort of causes the AMPK to be activated in the first place. That's LKB, and that's also upregulated specifically in the GVHD T cells. And I'm not showing you the Western blot here, but suffice it to say a number of downstream targets downstream of AMPK, including acetyl-CoA carboxylase. Again, a specific phosphorylation event is increased in these GVHD T cells. So having sort of shown that the pathway is potentially active in these cells, the next step was to see what would happen when we knocked it out. We used a simple sort of Cree-Lox system to eliminate AMPK alpha subunit in all of the T cells in the donor mice. So AMPK has two isoforms, alpha-1 and alpha-2. Alpha-1 is the predominant form in T cells, but we decided to be thorough to knock it out, both copies out. And so basically, again, what this results in is that all the T cells that we'd be using from these animals lack AMPK. Now, there were no baseline differences in sort of T cell numbers from these donor animals, and so it wasn't a gross defect in their thymic development or getting to the periphery or anything like that. So the next step was to actually put them into our transplant. Again, this is a sort of a slightly different transplant model, more like sort of the unrelated donor transplants that we do in the clinic. And now what we're doing is we're using either wild type or AMPK knockout T cells as the donor, putting them into these animals that have been lethally irradiated, and now measuring survival, weight loss, and clinical score to see how these mice do. And quite strikingly, when you do this, if you transplant the wild type T cells, again, survival is here on the y-axis, they almost universally succumb to the disease by the end of the transplant at day 70, whereas the recipients who receive the AMPK knockout cells, now these cells don't have any AMPK, have much better survival. Similar to this, there's a much less weight loss in the recipients who receive the AMPK knockout cells, whereas the ones that receive the wild type cells lose weight and continue to lose weight throughout the course of the transplant. So we thought that this is pretty exciting data, but we wanted to sort of reassure ourselves that we weren't just having a generalized lesion in T cells, and that they continue to have some of the important functions that we would want them to have, including a graft versus leukemia effect. And so we modified our transplant protocol slightly. Again, this is back into a parent into F1 model. And the one thing we added here is we added 10 to the 5th P815 leukemia cells or marked with green fluorescent protein so we could follow them. And then otherwise sort of ran this model, this time looking for how many leukemia cells were present on day 13. So we had a group that had wild type cells, a group that had AMPK knockout T cells, and a group that had no T cells, just as sort of a leukemia only control. They did have bone marrow cells, so they would reconstitute their bone marrow compartment, but they wouldn't have any graft versus leukemia effect. So you can see here, this is from the peripheral blood in the liver on day 13. This is just marking the percentage or total number of GFP positive cells on the y-axis. And you can see that the animals marked in red here that didn't have any T cells have an overabundance of leukemia cells, but whether the recipients received either wild type or knockout T cells didn't seem to make a difference in their leukemia burden at these early time points. We also went on to sort of look at survival curves in these animals. We know that this 10 to the 5th dose of P815 cells is lethal. And so what you'll see is that the wild type cells will extend the survival to a certain amount. And we wanted to see if the knockout cells would also extend it to the same degree. And in fact, they did. So what you see is about a 3 to 4 week increase in median survival in the animals that receive the wild type T cells, shown in black here. And the animals that receive the knockout T cells have the same extension of sort of the survival curve. Now, these are pretty intense conditions to sort of test these T cells. And so if the knockout cells were not performing as well as the wild type, we'd have probably seen it pretty readily here. However, in response to the reviewer, we did publish this a couple of years ago in JCI Insight, but in response to reviewer's question, we went ahead and did change in T cell doses over a 10-fold range of T cell doses and saw equivalent anti-leukemia responses over all of those doses, just to sort of reassure ourselves that it wasn't a single sweet spot dose that we had picked. So really the conclusions for the first part of this talk, and I am going a little bit quickly because this has all been sort of published, and I want to get to some of the new and exciting, and this is also exciting, but the new and exciting data, is that both glycolytic and oxidative metabolism are upregulated in these GVHD causing T cells. And the AMPK activity increases in these cells, and then the loss of AMPK decreases the GVHD severity. We've now done this in 4 separate models, 2 of which I've kind of shown you already, and I'm going to show you one more in a little while. Furthermore, importantly, the knockout T cells retain potent graft versus leukemia responses and still retain their in vivo cytotoxic potential. And I didn't have a chance to tell you this just in the interest of time, but the wild type T cells seem to outcompete the AMPK knockout T cells at very early times post-transplant. So if we look in CD4 cells proliferation on day 3, we see that the wild type T cells are proliferating more than the knockout T cells are. And the CD8 cells, it seems to be more of a survival phenomenon where we can come back in even one day after we do the injections, and we can see that the wild type T cells are surviving much better than the knockout T cells. And so we think a lot of what's going on here with AMPK is a really early event in the transplant process. This is important, as I'll get to in some of my later slides. So then, obviously, the question that we wanted to ask, having an interest in metabolism, is what impact does removing AMPK have on T cell metabolism? I'm going to just take one short slide to tell you about the Seahorse Metabolic Analyzer. For some of you in the room, this is going to be well known, and for others, this is going to be a refresher course. Again, what you can do, this is just showing oxygen consumption rate on the y-axis and time on the x-axis. And what you do is you inject different chemicals into the Seahorse Metabolic Analyzer. It's got basically a port system where you can inject things in, and then you can usually take two general measurements. One is how much oxygen is being consumed, and the second is how acidic is the environment. It's got a sort of a pH probe. And then you give it a number of different things like oligomycin to inhibit the electron transport chain. This should knock down the amount of oxygen consumption and increase glycolysis. You give it an uncoupler, this FCCP. This basically lets protons come willy-nilly across the mitochondrial membrane, and you sort of get a maximum oxygen consumption rate. And then you shut down the whole electron transport chain entirely with rotenone and antimyosin A. And really the parameters that we look for most in this sort of a plot are, what is the baseline oxygen consumption? What's their maximum oxygen consumption? What's the difference between the two, which is sort of the spare respiratory capacity? We'll tell you how much the cell basically has in reserve. At the same time, you can also measure the extracellular acidification rate, which is largely dependent upon lactate being excreted into the media. So in most cases, although not always, but in most cases, the data that I'm going to show you, the ECAR is sort of a proxy for the glycolytic process. So how did we do this? We went back to our model. We took out the T cells on day 7. We purified them, and then we put them into the Seahorse Metabolic Analyzer. This was done by Darlene Mondlish, who was a staff scientist in the lab at the time, and recently published in a Blood Advances paper from June. So when you do this and you look at the sort of oxygen consumption rates, this is perhaps not surprising to us because AMPK is known to influence oxidative metabolism. They start out at the same basal level. But now when you do them, ask them to do maximum capacity, you see that the wild type C cells are able to respond and have a little bit of spare respiratory capacity. The AMPK knockout cells do not, demonstrated here graphically for you over multiple animals. But the perhaps more surprising question is when we started to look at glycolysis. That's shown here. Again, the extracellular acidification rate is shown here on the y-axis. When you inject the oligomycin, what you see in the wild type cells is you see a sort of a glycolytic compensation, right? When the electron transport chain is no longer able to function, the cells need something to do to get their energy, and so they sort of switch over to glycolysis. But what was really striking is that when you did this with the AMPK knockout cells, now you're not getting the glycolytic compensation. So they're not able to do the oxidative portion of this, but they're also not able to do glycolysis. And we really think it's AMPK sort of playing at both ends that really is sort of giving us the benefits in the disease that we're seeing. And this really suggests that AMPK controls both oxidative and glycolytic metabolism in these alloreactive T cells. So then the question is, these have all been done in murine T cells or mouse T cells to date, and we really wanted to know, does the same thing happen in human T cells? And so to do this, we went ahead and ran a xenogenetic model of GVHD. And the way you do this is you take peripheral blood mononuclear cells that contain both human T cells and non-T cells. You inject them into irradiated immunodeficient mice, so the immunodeficient mice can't reject the human T cells as they're going in. And then this leads to, over the course of 50 to 75 days, development of a GVHD-like reaction in these animals. Now, we looked at earlier time points because we just wanted to know whether or not the AMPK pathway was being upregulated. And you can see here, both by Western blot as well as here graphically, that the phosphorylation of AMPK versus the loading control, which is LAMB1, increases over time. So this is very similar to what we were seeing in our murine T cells. We then wanted to know what happens when we got rid of or deleted AMPK in these primary human T cells. We used a CRISPR approach to do this. This is just outlined here. We take these healthy human T cells, stimulate them with anti-CD3, anti-CD28 dynabeads. About 3 days later, when they were proliferation. We'd electroporate in some ribonucleoprotein complexes containing Cas9 protein and a guide RNA targeting AMPK alpha 1. We then expand these cells in 7 to 10 days, and then either analyze them or put them into our xenogenetic GVHD models. This is just tide analysis showing you that our indel frequencies are upwards of 90% when we use this method to eliminate AMPK alpha 1. And this is just an immunoblot showing that a target downstream of AMPK, this phosphorylation of ALK1, is greatly decreased in the cells that are sort of seeing the guide RNA, but not in the mock electroporated only cells. So we felt pretty confident that we were able to get rid of AMPK signaling and went forward with the xenogenetic GVHD experiments. And that is, what happens in these models when T cells lack AMPK alpha 1. This work was done by Li Kai Sun, who is a very talented PSTP student. So we have a program at Pitt where students go to medical school for 2 years and then they take a year off to be in the lab and then they go back to medical school for 2 years. And so he accomplished quite a bit over his 1 year in the lab and 3-month summer rotation. Basically, he took the T cells, cultured them for 10 days and either mock or CRISPR'd out AMPK alpha 1, combined them with some autologous non-T cells, and then put them into the NSG recipient mice that had been lightly irradiated with 1.2 gray. And then we just measured the xenogenetic GVHD. Very similar to what we saw in our murine models, the recipients of the AMPK knockout cells had higher rates of survival than the ones that were receiving the mock cells. Furthermore, and this is largely what the model looks like, there's a lot of clinical score, which is sort of based on fur ruffling, hunched posture, and a lot of skin changes, was much more dramatic in the mice that received the mock treated cells than those that received the CRISPR treated cells. So we think that the same phenomena is holding up in our xenogenetic models that we were seeing in our murine models of GVHD. We then, of course, wanted to ask the metabolic question about these human T cells and put them into the Seahorse metabolic analyzer and sort of say, what are they capable of doing? We did this by recovering cells on day 25 when we knew there was going to be enough to purify them and put them into the Seahorse. The first thing we tested was just the tide again to make sure that there was still deletion going on in these cells, that they hadn't had an outgrowth of AMPK positive cells. And it's true they remain deleted. There's 88% of the cells have an indel in the AMPK alpha 1 locus. And similar to what we were seeing in the murine T cells, these cells again have difficulties with their glycolytic compensation. In other words, the ECAR rates aren't able to go as high in the knockout cells as they are in the wild type cells. Again, just demonstrated graphically here. So then again, in just the interest of time, because this has been published, impaired OXPHOS glycolytic compensation in day 7 knockout murine T cells. AMPK activity increases in the xenogenetic T cells. Getting rid of AMPK decreases the xenogenetic GVHD severity, and AMPK deficient T cells also lack this glycolytic compensation. So we wanted to ask the mechanistic question then, is what is causing this decrease in glycolysis? Because it seems to be occurring in both the murine and the human T cells at both early and late time points in the transplant. In a way we decided to do this is went back to our murine model again, pulled this T cells out on day 7, and then wanted to specifically look for targets of AMPK. And we did this using a sort of immunoprecipitation approach. So there's an antibody that's been developed by cell signaling that sort of recognizes a phosphorylated motif. So it's this LXRXX and then either a phosphoserine or a phosphothreonine. There's an antibody that detects that. And so basically we put wild type or knockout T cells into our model, got the T cells on day 7, then immunoprecipitated all the proteins that had this motif, and then compared to what was coming up different between the wild type T cells and the knockout T cells to sort of suggest what might be the AMPK targets in these cells on day 7. When we did this, we were able to sort of get 134 proteins by mass spec, which is a little bit, I think, more than we had anticipated. And this was done in collaboration with Bill Hobbs, who's been a long-time collaborator for me at the University of Pittsburgh. But what was really striking about this was that 4 of the proteins that were there in sort of reproducible and statistically significant ways in terms of being reduced in the AMPK knockout cells were glycolytic enzymes. So then we were sort of scratching our heads about this for a while and trying to figure out, well, what's going on and why are these 4 impacted and not other glycolytic enzymes? And basically, we came across this paper published by this group in Cell Metabolism in 2020. And they essentially were able to take and immunoprecipitate one member of the glycolytic complex. And they were able to identify that a bunch of other glycolytic enzymes are kind of sort of hanging out together with whichever one they would sort of precipitate. Now, in this case, they did it with SIRT2, but they also reversed it and did it with enolase and did it with some of these other things. What they posited based on their results was that, and this was done in activated T cells, what they sort of posited in their results was that in activated T cells, you have a bunch of these glycolytic enzymes that kind of come together and form like a supramolecular glycolytic complex. And then they all hang out together, and that's what makes the glycolytic machinery more efficient and allows you to have that really quick glycolytic compensation that we saw in the seahorse. So our working hypothesis, we don't have proof for this yet, but Allison, who's here in the audience, is working hard on this, is that AMPK does something to these other glycolytic enzymes, whether it's a phosphorylation event of one of the enzymes. We know aldolase is a direct target of AMPK, or whether it's some sort of structural component that AMPK is providing to sort of bring these together in a supramolecular complex. And this is what then makes these cells more efficient at this glycolytic compensation. In contrast, if you don't have AMPK, you don't have these phosphorylation events, maybe you don't have the structural component that is providing, and these enzymes stay separate, and they're therefore not able to operate as efficiently. I'll show you some very preliminary data that we have that we're working on this towards the end of the first part of this talk on this point. But the other question that we sort of had in terms of going for future directions is, can we pharmacologically inhibit AMPK? So everything I've shown you so far is a genetic manipulation, and it's great for sort of testing, but it's not necessarily great for translation to the clinic. And so how would we approach this? So we looked in the literature, and for a number of years, there weren't any good AMPK inhibitors at all. There's something called compound C, which is really it was really sort of non-specific and didn't always work and would probably inhibit a bunch of other things. And so then we were looking for things that might be more specific. And we came across this paper from 2018 that described this compound SBI 0206965. It was originally thought to be an ALK1 inhibitor. That was one of the targets of AMPK, but it was later found to be a pretty potent inhibitor of AMPK itself. So then we started sort of playing around with it in the lab to see if it would actually work in some of our T cell models. So the first model we put it in is what's called a mixed leukocyte reaction, where we take the T cells and we mix them with some sort of APCs that are from a different background. Usually this is from the F1 splenocytes. And then we treated this whole mix of cells with plus or minus this SBI compound at 3 different doses, and sort of just to see what would happen. You can see here that without any SBI treatment, you get really nice proliferation of the cells. The T cells are marked with a cell division dye cell trace. And so what you see is that there's some undivided cells here, and then there's a number of cells that have divided over the course of this MLR. You can see that there are fewer cells that are divided in the 3 micromolar treatment. And now in the 10 micromolar treatment, you don't see any divided cells at all. Important to this assay, though, what you're seeing here is that this undivided population of cells continues to stay around. So it's not that it's completely getting rid of the T cells entirely. It's just not allowing the T cells to proliferate in this particular context, which is very similar to what they might experience in vivo in a sort of a transplant GVHD setting. We then wanted to up our game a little bit. And instead of combining the SBI with the APCs and the T cells, we wanted to pre-treat the T cells for 20 hours. Because this is really ideally what we'd probably do in the clinic, right? We take the T cells out, treat them with a compound for a period of time, and we give them to the patient the next day. So we went ahead and did that. Again, experiments done by Lee Kai, this phenomenal medical student. So he'd treat them with SBI for 20 hours, he'd wash it away, then he'd put them in with the APCs and let that go for 3 days, and we measured the proliferation there. And the first thing that he noticed is that when you recovered them after 72 hours of being together, you saw fewer of the donor T cells as marked by CD45 and TCR beta shown here. When he looked at the T cells that were there, he also saw a decrease in the proliferation of the cells, both in the CD4s shown here and remarkably in the CD8s. So again, you don't have to have the SBI present in the MLR at the time of the assay in order for it to be effective. You can pre-treat the cells for 20 hours and you can get this effect. But then we wanted to really ask the next question, and that is as well, can we actually extend this to a GVHD sort of model? And in this case, Li Kai treated the cells for 20 hours, washed them away, and then he put them into our he put them into our standard murine GVHD model, and we just assessed for how many cells were present on day 7. So very similar to what we're seeing with the MLR. Now, you see that there's a decrease in the recovery of the T cells that have been treated with the SBI, but not in the cells that were treated with the control agent. Furthermore, in some experiments, we've actually seen a decrease in the proliferation of these cells, similar to the cell trace plots I showed you earlier, suggesting that it's not getting rid of all T cells, but it's largely getting rid of the most active or most activated T cells. Again, also consistent with the fact that we think AMPK is playing a very important role early in the GVHD process. Now, fortunately for us, in addition to SBI 02069, there's now a second compound called BAY3827, which is also even a more potent AMPK inhibitor. Fortunately, they also have different mechanisms of action. So we think that there may be a way for us to combine these synergistically together to get optimal sort of AMPK inhibition, and those experiments are ongoing. Now, the challenge is that neither of these is biologically available. And so we're sort of left right now with treating the cells prior to the transplant, which may have decreased side effects and systemic effects anyway. But we are interested in talking to people in the medicinal chemistry group or others to see if we can either make these either more durable or more biologically available. Finally, I did promise you that I would show a little bit of data on us working up this supramolecular glycolytic complex angle. And that is, we've been able to take wild-type T cells, stimulate them in vitro for 3 days, give them a little bit of oligomycin to really drive their glycolytic compensation, and then do an immunoprecipitation experiment. Here we're immunoprecipitating with enolase antibody. And what you can see is that we can get enolase back, we can get aldolase back, we can get GAPTH back. And now the question really is what happens in the absence of AMPK? And can we sort of see a difference now? Are these gonna, you're gonna immunoprecipitate enolase, but there's not gonna be as much of these other sort of associated proteins with it. And that has to be determined still. Finally, in this first part of this talk, I started out by saying that we have 134 proteins that we're able to isolate on this mass spec. I showed you the 4 glycolytic enzymes that we're interested in, but there are a number of other candidates that are also piqued our interest. I'm just showing you the peak area from the mass spec for 3 of them. What's really intriguing about these 3 proteins in particular, first of all, is they all had a greater than 3-fold decrease in the knockout cells. Their p-values were consistently less than 0.05 across samples. All of them contained a medium or high stringency LX, RXX phosphorylation motif, according to the ScanSite algorithm, which suggests that they really are legitimate direct AMPK targets and not indirect targets. All 3 of them are known to be involved in metabolism or glycolysis at some level. And 2 of the 3 candidates have known inhibitors actually which work in vivo. And so it could be if one of these is really the target that's driving a lot of the phenotype that we're seeing with AMPK, we could circumvent inhibiting AMPK itself and instead inhibiting one of its downstream targets. So these are also being actively worked up in the lab. So conclusions from the second part of this talk is that, or conclusions 3, I guess, from the third part of this. Pre-transplant treatment with AMPK-specific inhibitors appears to decrease the subsequent in vitro and in vivo function of these cells. We've identified 3 novel targets downstream of AMPK, 2 notably with in vivo inhibitors that could serve as potential targets to decrease GVHD while still preserving GVL and immune reconstitution. Okay. Are there any questions from the audience at this point? This is the talk is kind of sort of bimodal here. So, yes. Yeah, she's gonna she'll bring a microphone over, and then that way people on Zoom.
So this is really fascinating. 2 really quick questions. One is, did you measure whether the human cells also alter their oxidative phosphorylation? And the second question is in the supramolecular complex. Do you know what happens if you change the AMPK phosphorylation site in aldolase?
So in the human cells, we did both an in vitro assay and then we also put them in the xenogenetic model and pulled them back out. In the in vitro assay, yes, there was a lesion in the oxidative metabolism in those cells. There was not a lesion in the human cells on day 25 in terms of their oxidative metabolism. Whether that just has to do with the xenogenetic GVHD model at day 25. It's really harder to get cells at day 7 or day 11 when their oxidative metabolism may be higher. What we sort of think happens is oxidative metabolism is really important really early on and kind of goes away, and then glycolysis is this sort of thing that kind of is consistent throughout the course of the disease. So that may be why we're not seeing it on day 25, but certainly in vitro, the human cells also lack the oxidative component. We know what we think the target site is in aldolase based on the scan site algorithm and this canonical motif. We haven't mutated it yet to know what happens in its absence. The first thing is just to really prove that aldolase is actually being phosphorylated by AMPK in these sort of contexts, and that's what we're working up now. It turns out especially co-immunoprecipitation is a little tricky sometimes, but we're working on it. So, yeah.
Great up to now. I'm enjoying it. I have two questions. First, you keep mentioning CD4T and CD8T. Did you ever look at the proportion of Tregs in the CD4T population? Because we're talking, AMPK and
yeah, no, we did, and that was part of sort of the JCI Insight paper was asked for by a reviewer to detail more of the Tregs, and what we saw is that in the AMPK knockouts, we did see an increased percentage of Tregs. You don't, in this GVHD model, there's not many there at like day 7 or day 14 yet. You will attest to this. But there are some there, and they were there in higher percentages if the mice had the knockout T cells. We then went and got rid of all of the Tregs and ran the model just with effector cells that were wild type or knockout, and we still saw very significant differences in disease. And so it would sort of suggest that, yeah, there is a difference in Tregs, but doesn't explain all of the difference in disease that we're seeing.
But did the metabolism change then, in the absence of the Tregs? Because I was just thinking some of your profiles might have to do with the Treg contribution. So.
Right, maybe, but I mean, the Tregs are on the order of less, 1 to 3%, and so they wouldn't.
Yeah,
we thought to influence it too much, but we haven't done that. That's a good thing to sort of think about.
The second thing was just a comment is that we were looking at the phosphatase trying to identify the phosphatase for AMPK in T cells, and we have a lot of AMPK knockouts in Jurkat T leukemias that might be useful for your IP experiments. That might give you an insight.
Oh yeah, that's great. Yeah, because it's a T cell based thing, and so maybe we would have other candidates to look for. That's great. Good. And Sandy, I'm assuming nothing on the chat so far.
I do have a couple. Do you have more presentation?
I do. Well, maybe I'll take those at the end, and that way I'll get through, because there's some exciting data still to come. So I don't want to shortchange that. Okay. So then, so the first part of the talk, I talked about getting rid of AMPK and how that could be beneficial in pathogenic cells, but then people in the lab started wondering, well, would there ever be a situation where increased or enhanced AMPK signaling would be beneficial? In other words, for example, to increase T cell persistence. And so then you have to start thinking, well, what are the situations where you'd want to have your T cells sticking around longer? And obviously the one that we thought of was a lot of these sort of cell therapies. So this is just basically a schematic here on the left of production of chimeric antigen receptor T cells. And where you take the cells out of the, individually, you transduce them with a chimeric antigen receptor or T cell receptor of interest to sort of educate them to target a certain leukemia. CD19 is a classic example. And then infuse them back into the patient where they then sort of get rid of the tumor for you. These have been remarkably successful. Cure rates of previously incurable cancers, you now have survival rates on the order of 50 to 60%. And particularly for leukemia. But the problem is that you're still having 40 to 50% of your patients suffer from relapse. About half the time it's because the tumor itself changes, and so they mutate CD19, so it's no longer recognized by the T cells that you put in. But about half the time, 20 to 25% of the time, it's because the T cells themselves don't persist or don't function very well in vivo. And so we really thought we could maybe target this 20% down here through some of our metabolic modulation. Well, is there any evidence that metabolism plays a role in CAR T cells? And people that are familiar with this field will know this classic paper from Carl June's lab in Immunity in 2016, where they took two different CARs. One had a CD28 co-stimulatory domain, one had a 4-1BB co-stimulatory domain. And they were able to basically demonstrate that the ones with the 4-1BB CAR had an increase in oxidative metabolism, which they then suggested was leading to an increased persistence of these cells. And that's why the 4-1BBs outperformed the CD28s in their hands. So we thought to ourselves, can we activate AMPK in some fashion to drive oxidative metabolism and enhance T cell persistence, essentially to take the CD28 CAR, which has a great initial response, it just doesn't stick around, to in the end behave more like a 4-1BB CAR. So we went back to thinking about what AMPK, how it functions. Again, the kinase domain is in the alpha subunit and phosphorylates downstream targets, and the regulatory domain comes in and sort of protects the alpha domain and keeps it phosphorylated so it can sort of function longer. So we thought to ourselves, so what happens if we simply overexpress the gamma regulatory subunit and give ourselves more protection? Are we going to enhance the AMPK signaling? So we're not mutating it in any way. We're just giving more of something that it already has in lower amounts. This is just to show you that we can do this. We can get really nice levels by of RNA by RT-PCR, 7 to 8-fold increase. We see a nice increase in this AMPK gamma isoform C, which we put into the cells. If you look at the actual AMPK signaling, now the AMPK signaling increases shown here in lanes 2 or columns 2 and 4. These are the gamma 2 constructs and CD4s and CD8s. And we also see nice phosphorylation of downstream targets. So it looks like just by putting in more gamma into these T cells, we have an increase in the AMPK signal. So what happens? So we can make those into CAR T cells. This was done by Meng Tao Quinn, who is a visiting scholar from Tsinghua University in China, currently finishing her PhD studies with my group. So she was able to transduce these to make them CAR T cells, and then did a second lentiviral transduction to introduce the AMPK gamma 2 or an empty viral construct with GFP so that we could track this. We then took these metabolically induced CARs plus or minus the AMPK gamma 2, exposed them to the CD19 targets. This would be a NALM6 cell in vitro, and then took those CAR T cells out and put them on the Seahorse metabolic analyzer. And what you can see is that very nicely is giving the AMPK gamma 2 to these cells increases their oxidative metabolism, again, specifically sort of the maximal and the spare respiratory capacity compared to the empty viral CAR T cells. The next question was as well, does it impact their function at all? And so we did is we took these CAR T cells and we now co-cultured them with a ZS green NALM6 cell line. We did this in low glucose RPMI media to really sort of stimulate the AMPK pathway. And we did this in an effector to target ratio of 1 to 3, so really in favor of the target cells. And what you can see here is that, again, this is an IncuCyte assay, so what you're measuring is the green intensity, which is the NALM6 cells in this case. And the quicker or steeper these lines go down, the more the leukemia cells are being cleared. And you can see that the AMPK gamma 2 CARs clear the leukemia much faster than the empty vector CARs do. We wanted to sort of up the game a little bit. And so instead of using the sort of standard low glucose RPMI media, we instead used conditioned media. This is essentially media that NALM6 cells have been grown in for 72 hours. And so there's all kinds of things that the NALM6 cells are eating up or donating to the media. We'd sterile filter that and then put our co-culture assays in that. And here what you see is that the leukemia cells don't go away quite as quickly. In fact, they start going up a little bit before they go down. But even under these harsh conditions, you see that the AMPK gamma 2 CARs have an advantage. So then the question was, well, what happens in vivo, and are we going to see these results play out in vivo? We use an immunodeficient NSG sort of a setup to ask these questions. So on day -7, the NSG mice get 1 million NALM6 cells. 1 week later, they get 3 million CAR T cells that are either had the AMPK gamma 2 or an empty vector transduced in. And then we measure survival and weekly IBIS imaging to show luciferase staining, because these NALM6 cells are luciferase positive. Unfortunately, I'm gonna cut to the chase on this particular survival curve and not show you any of the radiance data, because despite the really impressive cytotoxicity events in vitro, we were not seeing a real statistically significant difference in the survival of these mice that got these AMPK gamma 2 CAR T cells. Now, notably, this does need to be repeated. We're also we did this with a CD28 CAR. We're also in the process of repeating it with a 4-1BB CAR, where we think we might get a little bit more mileage out of it. But needless to say, it was not the home run that we were sort of hoping based on what our in vitro studies showed. So then we went back to the drawing board and said, well, is there an alternative way to increase AMPK signaling? And there is. You can actually increase AMPK signaling with an agonist. And actually, in contrast to the inhibitors, where there's sort of few of them, there's lots of different AMPK agonists. But you do have to think a little bit about how you want to sort of stimulate the AMPK signal, because there's some things like metformin, which is an indirect activator of AMPK. Basically, what metformin does is it makes the cell feel a little bit starved. And then because of its starvation, the cell will then kick in and upregulate AMPK activity. So you get the AMPK activity, but you are also kind of like half starving the cell. There are other agonists like the one that I'm going to tell you about this morning, where it's an actual direct activator of the heterotrimer. So you don't actually have to starve the cell. It just kind of goes in and activates things. So you get all the benefits of AMPK activation without any of the starvation. So again, we lentivirally transduced our human T cells to create CAR T cells. This process took about 5 days. Then we simply gave 2 sort of days of metabolic enhancement, 48 hours each, on day 7 and day 5 and day 7. We washed the compound away on day 9, let the cells rest for 48 hours, and then we either evaluated them further or we injected them in to our NALM6 tumor model. This is just to demonstrate that if you take those cells on day 9 after they've seen 2 doses of this agonist, they increase their oxidative metabolism, as I've shown you both for AMPK gamma 2 as well as some of the other things in this talk. And going forward, just for the purposes of these slides, we did use 2 levels of agonist treatment, both a 10 micromolar and a 25 micromolar level of agonist treatment. So again, what we did is we lentivirally transduced the cells to get CAR T cells, metabolically enhanced them, washed them, rested them, injected them on day 11. And we were using, again, our NALM6 model. So the NALM6 cells went in, and then these day 11 agonist-treated or vehicle-treated cells went in on day 0. And then we measured IVUS imaging or survival. And this is where things got a little bit more interesting. So this is just an example of animals that have received leukemia only. And so that you have a rapid sort of tumor growth as measured by the radiance levels here. And now this is what it looks like when you have the untreated CAR T cells. And so almost universally, all the animals begin to have leukemia growth by about day 40 in the experiment. 0 out of 6 of these animals survived to the end of the experiment leukemia-free. Now, however, when you have treated the cells with this agonist, you start to see some really sort of profound benefits. So first of all, the 10 micromolar dose, you're starting to see, there's 1 animal that has leukemia that develops early, 3 of them develop it late, and 2 of them are leukemia-free at the end of the experiment. And now in the highest concentration of agonist treatment, 4 out of the 5 of the animals are leukemia-free. 1 of them survived until the end of the experiment, but obviously had leukemia that would have needed to be euthanized in the near future. So what this does is it creates a very nice survival curve where you're able to extend the median survival from leukemia-only mice with the untreated CARs by about 3 weeks. And you're probably going to extend it, especially with a higher dose of the agonist treatment, another additional at least 3 weeks, if not longer. Based on the fact that we didn't see any leukemia, those mice may have survived indefinitely. It's really hard to know. Okay. So then the follow-up questions for this part, and then we can get to your questions at the end, is what is the underlying cause of the improved leukemia clearance in our models? And so we did a couple of in vitro tests and 1 in vivo test, but this is really still an open question and something that my lab is going to work pretty actively on and in the first 6 months to a year that I'm here. And that is, the first thing we did is we just looked at sort of proliferation of these cells. And we did this with BRDU, and we did this at different time points. I'm just showing you a day 9 time point here. BRDU is shown on the sort of x-axis as a histogram from either CD4s or CD8s, and day 9 from either DMSO treated or compound X treated cells. You don't see any difference in the BRDU incorporation, meaning the proliferation on day 9 is equivalent. Now, however, what's really interesting is you look on day 11, the cells that have been treated with DMSO have about the same level of BRDU incorporation, about 25%. Now this is almost doubled in the cells that have been treated with the agonist. So what we think is there may be some sort of a rebound effect that when you have AMPK agonist on, the cells are doing something else, and then when they come out of it, they come out kind of ready to go, and we just happen to grab them at that day and put them into the animals, and this is potentially why we're seeing some of our benefits. We also backed up to day 9 because we were again interested, as you alluded to in your question or comment earlier, about what are the actual targets of AMPK in this, right? Because I think that would sort of mechanistically define what's going on and give us potentially additional targets. And so again, we harvested the cells and we just simply did a phosphoproteomic screen to say what were all the pathways that had upregulation and phosphorylation of particular residues. And we saw this really nice sort of plot over here where we're seeing a number of candidates now that are both having log 2 fold changes in anywhere from 5 to 20 fold, as well as a really nice p-value. Remarkably, scattered within there are about 4 or 5 predicted AMPK targets based on scan site that we think are legitimate targets that are being targeted by AMPK that may be having a role in their ability to sort of go on and perform these heroic in vivo functions. Obviously, these are now the top candidates that we're working up further. And finally, we went ahead and did some early experiments after the cells were transferred into the null 6-bearing animals, both at day 3 as well as week 1 and week 2. And we're looking for both BRDU and cell number. Cell number first, if you look at day 3 and pull them out of either the spleen or the bone marrow, what you see is there's really no difference in cell number at this very early time point. So it doesn't appear that there's something that happens within the first 72 hours. However, now quite strikingly, what you see is that by week 1, you're now starting to see an increase in CD4 numbers, both in the spleen and the bone marrow, but only in the agonist-treated cells. Furthermore, because the CD4s are outpacing the CD8s, this does create a little bit of a CD4-CD8 ratio difference between agonist-treated and control-treated, and that's just demonstrated here. And the CD4-CD8 ratio, where the CD4s perform even better, is sort of even exaggerated even more by week 2. Notably, this is what's somewhat surprising to us. We did not see any BRDU advantages for the agonist-treated cells at any of the time points examined. What this means is that they may be more proliferative in vitro, but it doesn't appear that they're more proliferative early on in vivo, suggesting instead that perhaps the CD4s are either more resilient, either surviving better or having less apoptosis or something. This is yet to be determined, and obviously the point of ongoing studies. So again, the conclusions from this last part is that AMPK gamma-2 transduction increases oxidative metabolism and improves in vitro cytotoxicity, but notably didn't have any superior anti-leukemia effects in vivo. This needs to be repeated. I do think that the gamma-2 construct could be important for other environments outside of leukemia, such as a solid tumor environment, where you might need more longer duration of AMPK signal, or the microenvironment may be more harsh. And this is work that's being done by my Tsinghua medical student presently. However, excitingly, we did notice that the treatment of CAR T cells with this AMPK agonist in vitro improves their subsequent performance in vivo, noted by tumor clearance and recipient survival. And the things that we were able to determine so far is that there was an increase in vitro proliferation in these treated cells just prior to injection, and an early increase in sort of post-transplant or post-injection CD4 T cell survival. I do want to acknowledge the members of the lab that did this work. I still have sort of 2 students with me. Felicia Kemp's the graduate student whose work I did not present today. Mengtao Quinn did a lot of the stuff with the day 3, week 1, week 2 studies. Past members acknowledge my funding sources, including a DoD grant from the, it was an IDEA award that sort of culminated in a lot of generation, a lot of this data, as well as a Curing Kids Cancer grant that just finished up. And finally, I want to make that shameless plug that all new PIs to the institution make, is that we are recruiting all levels of trainees. And so if you guys have friends or people that you know that are interested in metabolism or immune cells or some combination of both, please have them email me. But happy to take questions for the last 5 to 10 minutes here. So.